study the patient, after talking to the patient. These are the points very important. While people who have read my talk last year, they will understand, remember that I am very fond of this particular statement, and I always mean it. I don't think you can emphasize more than what I am doing. Please understand, it is not true only for style examination, it is true for every examination, but probably more true for style examination. Always form a fixed sequence. When you are preparing for the exam, please form a fixed sequence in your mind. Write it down, put it in the city of the staging mirror or in a quick area, so you can see daily. The idea is to not miss any point, and when the exam is under tension, and you may not be at your best, you will not forget anything. Please do in a absolutely a fixed sequence which is for you. This is a sequence which is recommended. Inspection, palpation, movements, measurements, special test and spine examination is not complete without a rules examination. We go step by step and see what we can see. If a patient of a spine disease is allowed to walk and able to walk, both things are important. Many patients of spine disease are not able to walk, and even if they are able to walk, they are not allowed to walk. If the patient is able to walk and allowed to walk, then we may discover something in the gait which can give an idea about the ultimate diagnosis. I'll show you two examples. Different gaits which you can see in a patient of spine disease could be a painful spine guarded gait, and so forth and so forth. I'll show you two examples. This is a typical gait of a patient who's got ankylosing spondylitis. You see the whole spine is stiff. The spine, the sacroiliac joints and the hips are simply moving in one segment. And one small thing, if you see the upper limbs, they are showing more movements than normal, because they are comparatively less involved. Upper limbs are rarely involved, joints of the upper limb, upper extremity are rarely involved, and the patient tries to propel himself with the excessive movements of the upper extremity of both sides. This is a patient who has a own case of fracture of the spine. He has recovered partly with the paraparesis, and he has got a bilateral foot drop. When he turns around, you can see the old spinal trauma. There is a deformity there. This is hinting for the old spinal trauma. This is diagnosis very obvious from the gait itself. Patient of old spinal trauma with a partially recovered paraplegia. Paraparesis remaining. This patient, is a typical patient of a sciatic scoliosis, a patient who has got an abnormal shift of the spine because of an acute disc prolapse, trying to take the painful area away from the extruded disc. Sciatic scoliosis is different from the routine scoliosis. As you see from the other photograph, there is a sudden shift of the spine towards one side. The photograph below shows you there is a sudden shift of the spine towards one side. It is not a rotational deformity of a true scoliosis. It is also called a list or a sciatic scoliosis. And this sciatic scoliosis, as the patient bends forward, it disappears. It disappears, the scoliosis, the list, there is a sudden shift of the front scoliosis disappears, and as the patient gets upright again, it reappears. The typical example of a sciatic scoliosis because of the extruded disc. This is a patient of a electroneuropathy. The gait is broad-based. There is a little hint of staggering, particularly when it turns around. It is more clear in the other patient. There is no lesion this here. Spasticity, staggering, wide-based gait. Staggering is obvious when the patient turns around. The upper limbs are also you can see the other patient, the upper patient, the hands and the using the hands also. It looks like staggering. Yes, that's right. A typical example is right from the Now, after finishing the gait, these are the normal patterns you can see in the gait. I mean, not normal. Common patterns one may see in a patient of spine disease. Now, before we start with the inspection, an idea of this all is very only. one should see the attitude of the patient. Does the attitude convey anything particular? This child you see is supporting the chin. It's a typical stance, particularly seen in children. You can see in adults also, but very common in children, where the child is supporting the weight of the skull with the head because of a painful lesion in the cervical spine or the upper dorsal spine. The other patient, this one, has got a painful lumbar lesion. He is trying to bypass the weight of the body by taking the weight of the trunk directly to the knees, so that the weight doesn't pass through this area, which is obviously painful and a lot of spasm. You can see the straightening and the spasm. So this attitude can give you an idea. The first child has got a painful lesion in the cervical spine or the upper dorsal spine. The other patient has got obviously a painful lesion in the lumbar spine. Now, come to inspection will be from the back, from the side and the front. These are all the points which are seen from the back or from the side or from the front. I show you by example. I try to run them quickly. Inspection from the back. Just see the position of the head, whether the head is central or not. The normal one is center. This child, because of scoliosis and the shift and the rotational deformity of the spine, the head is not central. There is no fixed definition for hairline. It's just a visual impression. In the photograph on your left, is a normal photograph with normal hairline. In the other photograph, the hairline is low. There is no definition in the books, but it is a visual impression. You can obviously say this patient has got a low hairline. Again, there is no definition for a short neck. Length of the neck is not described as such, but it is a feeling or a visual impression. Like in this patient who has got a short neck because of multiple collapse of lower cervical and the upper dorsal vertebra. As you can see in the X-ray, mostly the upper dorsal. Continuing the inspection from the back, look at the level of the shoulders. And shoulders will be the same level in a normal person. In a person who has got scoliosis, they will be at a different level. Position of the scapulae. Scapulae are mostly at a different level. If the patient has got an underlying congenital vertebral disease, like in this patient, a case of multiple congenital block vertebra. You see the scapula on the left side is at a higher level, or the left side of the patient is at a higher level. To make a note of that, even if it is on a higher level, these points you should remember. It should come automatically. Head is central, hairline is normal, shoulder at the same level, scapula at the same level. Lateral margin of the body in a patient, a normal person, will be absolutely symmetrical. On two sides. In a patient of scoliosis, they will obviously be asymmetrical. Concavity will be concavity on the lateral trunk will move to one side, concavity of the spine, and then we have transverse crease. Now this transverse crease is very typical. In the case of acute concavity of the spine, this transverse crease will also be there. Continuing the inspection, one may appreciate on inspection itself a step in the lumbar spine because of the case of spondylolisthesis. Like in this patient, that it has a step, and if you notice, around the step, this small crease is there. It indicates a slip of the vertebra. This step is mostly better palpated than seen. It is seen only in two patients. Do not rule out spondylolisthesis if you do not see a step on inspection. It may be present on palpation. Talking the pressure of the spine, I've already discussed about this concavity. The only thing that I want to tell you that once you describe a scoliosis, you must describe the area or the area of the spine. Which is when talking about scoliosis, the tendency toward the right side. I spent some time on this slide because it's difficult to understand. This phenomenon which I'm going to describe happens more often in children, can happen in young adults also, but more often. You see this child has got a posterior rib hump on the right side and an anterior rib hump on the left side. I hope you will appreciate from the photograph. Yes. Posterior rib hump on the right side and anterior rib hump on the left side. Why is so? In the case of scoliosis, the vertebral body rotates towards the side of convexity. It takes the one rib or posterior rib on that side, and one has got a posterior rib hump on the side of convexity towards the which the throttle body is rotating. On the concave side, where the corresponding rib goes in the opposite direction, and there is a anterior reform. This is seen on the side of concavity. Anterior reform on the side of concavity, posterior reform on the side of convexity. This is typical of children, where it never be seen obvious in adults. When inspecting the back has got 2 more points, you can make note of any swelling or any abscess, and as the abscess is suspected, it can be confirmed with aspiration. A central furrow on the back, there is an impression about the normal furrow, there is an impression about the deep central furrow, or exudent central furrow, and there is an impression about obliterated central furrow. One example you can see of this, there means the central furrow is deepened. Because of muscle spasm, you can see the muscle spasm, very obvious muscle spasm, and because of that, the central furrow is deepened. In a patient of wasting, the central furrow will be, or if there is a kyphotic deformity, towards kyphotic deformity, the central furrow will be decreased. Make a note of any scar, signs of visual possession, as usual in any case. Now, this is an example you may find in a child. You must have read in the books, this is a very typical example of a spina bifida with a tuft of hair. You see this tuft of hair, and never forget to examine the lower extremities completely in this patient. You may find things like this, a congenital vertebral teres in the same patient because of a deficit and insulin deformity. This was confirmed, the same patient was confirmed with MRI contrast MR. This is a small measurement again, small visual measurement, again to tell you whether there is a history of the trunk or not. This vicus rhomboid is supposed to be drawn between the spinal fossa of L5, the 2 posterior fossae, and the uppermost point of the reticulate. It is supposed to be absolutely symmetrical and normal purchase. In a patient who has got scoliosis, particularly towards the scoliosis goes towards the lumbar spine, this may be the asymmetrical. Now, the triangles at the base are made by the lateral side of the trunk and the medial side of the upper extremity. Normal patients, they are symmetrical. In a patient who has got scoliosis, these triangles will be asymmetrical. As I am inspecting from the back, now this was inspected from the back. Let us go for inspection from the side. You look for the arm for the low there is a normal dorsal kyphosis and a normal lumbar lordosis. In a patient, this lumbar lordosis may be absent in case of this is a patient of endothelial spondylitis. This is the lumbar lordosis absent. You have always heard about increased lumbar lordosis in the hip joint. This is absent lumbar lordosis because of endothelial spondylitis. One must make note of the abnormal kyphotic deformity. As you know, the kyphotic deformity could be of 3 types. It could be knuckle, angular or rounded. Knuckle is 1 vertebra, angular is 2 or 3 vertebra, and more than 3 vertebra is rounded. This is a picture of rounded kyphotic deformity. And the example of the same thing. Continuing the inspection on the side, a sinus in the neck is more appreciated from the side than from the front, like in this patient. This patient had a clean spine, so the discharging sinus in the neck. There is more appreciated on the one to examine from the side. Same thing, the swelling in the neck is also appreciated more from the side than from the front. You can see both the photographs. It is much more appreciable from the side. So this patient has got a huge swelling. It is seen from the front also, but better comment from the side. And this was the case of again radiating lymph nodes. Especially from the front, this patient has got a made one of very swelling, like in this patient got a cold abscess because of the tail spine. Corresponding picture are there. We want to confirm whether this swelling on the chest is because of the cold abscess or because of the lesion in the spine or not. Both things are quite far away. A spinal lesion causing the abscess in the front of the chest. you want to confirm, do an schistogram. And one can see, with the schistogram you can see a small faint track going from the access cavity towards the spine. This is a track. And a schistogram can confirm. And now, especially from the front, make note of any extra prominence of the chest which can be present in case of gross dorsal-kyphosis. Position of the anterosclerotic spine must be made note of. Besides the hip disease, these 2 points can go into oblique, can be asymmetrical because of the problem of the spine also. This is an example of a posterior visual paralysis with a scoliotic deformity of the spine and a fixed pelvic obliquity, in which the anterosclerotic spines are at a different different levels because of scoliosis. This was all about inspection. I told you the sequence. These are all the points you will see in inspection. Now we will go to palpation. The first 2 points to be seen in palpation in any area of the body, in any branch of medicine. Not in any branch of medicine, in any area of the body are local temperature and tenderness. Local temperature is seen first because of humidity. Why we see local temperature? The very first point. Because the temperature of the local part may change in the headache. You do other examinations before the local temperature. The local temperature may change. So first see the local temperature with the back of the hand, not with the palm, with the back of the hand, that's shown in the photograph. Then see for the area of tenderness. That is the second point to be seen in any examination, in any part of the body, in any branch. So you want to avoid any tender area in further examination. This is again a video of the local temperature. Just hold the test. Actually, this is done with the help of the fingertips. So that for the ease of taking photograph, it is done with the thumb, but it should be done with the fingertips. The fingertips should go right from cervical spine to the last vertebra, and these fingertips should be able to appreciate any area of deformity, any area of deviation, or any tenderness. This is called Holz's test. The step, again with the Holz's test, and then you can, once you detect an area, suspect area of deformity, confirm this by your localized examination of the area where there is step of deformity. Now, palpation, as the tendon is concerned, there are different methods that we described. It could be simply tapping on the paraspinal muscles may induce tenderness, or tapping on the spinal process may induce tenderness. Third tendon gently putting a fist like this. In case of spinal process involvement will be tenderness. Then the rotational tenderness is there. Now, please, I spent some time. I will do that. One must understand the concept of rotational tenderness. In a patient of spine disease, particularly in India, whatever is available to you for examination is a very small part of the body. You can palpate only the spinal process, and maybe the base of the spinal process. The rest of the vertebra, lamina and the body and transverse process are mostly covered with the muscles. You are not able to palpate them. But a disease most likely is present in the anterior part of the vertebra. But what is available to you for examination is the posterior normal part. So by examining the posterior normal part, you are trying to elicit any sign from the disease interior part. There is a fundamental of this rotational tenderness. By rotating the spinous process, you attempt to rotate the spinous process, you transmit the rotatory movements to the disease interior part, and that is not painful. So rotate the spinous process, which is normal, may elicit tenderness in the disease anterior part. That is the basis of the rotation tenderness. You must always do a direct tenderness as well as rotation tenderness in the case of spine. There are two ways of doing eliciting rotation tenderness. One thing is that you can put the base with the tip of your thumb at the base of the spinous process and try to rotate it. Or else you can catch hold of two adjacent spinal processes and rotate them in different directions, like here. Both the maneuvers will elicit tenderness if it is possible. This is direct tenderness, and this is rotational tenderness. By the side of the spinal process, the clip on the top, the lady shows the direct tenderness, and this is by the side of the spinal process, and the same tenderness. Now, once in the palpation, you must mark, and you must be ready with these markings when the examiner comes to you. The areas you can mark are C7 capital prominence, the most prominent vertebra of the spine. D1 is the longest spinal process. D3 corresponds to the base of the spinal scapula. D4 is the distal level, so and so forth. You must mark all these points before the examiner comes to you. With the help of this marking, you can be sure of the exact area of disease. You find elicit tenderness at D4, you will find that it is just beneath the area which is marked as D3. That is the basic logic behind marking this area. Use a good marker pen, like in this case, don't use a ball pen. Palpation, one may see the muscle spasm, or one may palpate also. The muscles may be found to be spasm or palpation. If there is a spasm is gross, it will be seen. Sometimes the muscle spasm is not obviously seen. Tapping over the press on the muscle may elicit the spasm. In a case of like this patient, tapping on the area uses the muscle to go to spasm. This small test which is described as tubular test for appreciating the muscle spasm. It is not a huge test that you must measure it, but you must be aware since you are posterior students. It is described as tubular, in which he holds the skin fold, full thickness skin fold between the thumb and the index finger, and tries to move it in the direction of muscle fibers. It is said that when the underlying muscle is spasm, this movement will be reduced. This is what is tubular test. Now, this is just a summary of the palpation which we have done till now. You must please make a point and go these points right. You will not miss anything. Now that's some movements. Again, please resist in checking in examining movements in every patient. Movements should be checked in those patients where they will not harm the patient and where the patient can do that comfortably. Different movements can be checked the flexion, extension, and rotation. You see one by one. Flexion in the dorsal spine can be checked by these methods. I showed them to do that. So normally, if you ask the patient to bend forward and try to bend the feet, it is a combined flexion movement which is having at the dorsal lumbar spine. This is a combined flexion for dorsal lumbar spine both. Make a note of whether the patient is able to touch the floor or not, and if he is not able to touch the floor, until what point the patient's fingertips reach. They may be reaching, like in this patient, the upper part of tibia. And if the patient improves the treatment, in the next visit they will go to the middle of tibia. That is the basic idea. Now this is a old test when you want to examine the flexion movement of dorsal spine exclusively. When the patient is standing, the zero mark of the face is kept at C7, and 30 centimeters is supposed to cover the whole dorsal spine. 30 centimeters is kept like this, and then you ask the patient to bend forward and see how much this 30 centimeter mark moves. Normally it should be around 3 centimeters, which is a combined flexion movement in whole of the dorsal spine. Similarly for testing flexion in the lumbar spine, use Schrober's test or modified Schrober's test. In Schrober's test, a 10 centimeter mark of the different case is kept near the dimple of Venus, and the zero is above. Ask the patient to bend forward and see for the movement of for the how much movements are in the lumbar spine. They should be around not less than 2 centimeters. Modified Schrober's test is described. is similar except that the 15 centimeter length of the tail is used. 10 centimeters is kept at the previous age of temple of Newman, and the other point is kept at the below. It is supposed to take the complete movement of the lumbar spine, including the lumbar tension also. Second is checked in this manner. The lateral flexion is the movement which occurs in spine. Again, movements are different from the floor or from the leg like this. Or you can see the direction of the trunk from the body. Now, if the patient is allowed to sit, then the rotation of the dorsal spine should be checked in the patient is sitting. I hope all of you know that the rotations are present only in the dorsal spine, they are not present in the lumbar spine because of the typical configuration of the facet joint. Facet joints in dorsal spine are so oriented that they do allow rotation. Facet joints in the lumbar spine they block rotation. They do not allow rotation. Whatever rotation is happening only in the dorsal spine. This is how to measure it. If the patient is not able to sit or not allowed to sit, you must send the exam that I have not checked the spinal movements because the patient is not patient disease or the symptoms may increase and the patient is very painful. That is why I have not examined the spinal movements. The movements are the spine is nodding as well as the occipital joint. Patient is having a occipital joint. This is how we see for examining the flesh. One thing which most of you forget, in a young male with a spinal disease, must never finish the examination without recording the chest expansion. As you know, the measuring tape is kept at the level of the nipples. Patient is asked to exhale completely. The measurement is noted. Then the patient is asked to inhale fully and hold for a second and you keep the chest expansion. The patient has got a normal chest expansion. Normally it should be more than, it should be near 5 centimeters. If it becomes 3 centimeters or lesser, it becomes very suspicious of a disease, like in the patient. There is hardly any chest movement in this patient of ankylosing spondylitis. And the movement, the rib hump which is present in children becomes more prominent as the child bends forward. Kaneja, who is also holding a regularly, is very fond of messing on thermometer. There is a device, there is a water level which is supposed to measure the height of the rib hump. Now this is just a summary of measurements of the movement which we have seen. Now there are two special tests. If you are suspecting disease in the upper lumbar area, one must do this test. The patient lying prone, hip is extended, with the knee flexed, attempt is made to hyperextend the hip. If the patient has got a painful lesion of the roots of the upper lumbar spine, the patient will complain of anterior side pain. This indicates, since these roots are put at test because of this maneuver, if there is any disease which is involving L1, L2, L3, this is called pain in the anterior side. Now, starting the suspension, recent test is a straight leg raising test. Patient lying supine, the knee is extended. The examiner passively, not actively, passively, lifts the leg off the bed and look towards the face of the patient. If the patient has got an active risk for that, at a certain point the patient would wince and convey into the kind of pain. Stop at that point, measure the angle. That is a straight leg raising test, or latest test as it is called. Further modification of, please know and make a note of that angle when the patient starts complaining of pain. An extension of this test is Brigard test. At the angle at which the patient complains of pain, take the leg a little down. Pain would disappear. Once the pain disappears by taking 2 degrees down, 2 degrees, then passively dorsiflex the ankle. Pain would reappear. This typically indicates a stretching lesion at the nerve level. Regardless. Cross-sectional test is present if the patient has got symptoms and this could have on the left side. Sometimes raising the right side limb in the manner shown can cause pain in the left leg. Raising the right leg causes pain, reducing pain in the left leg. This happens in case of a central disc prolapse or a large disc prolapse. These are the must not finish spine examination without successful sacroiliac joints. These are the 4 different tests which have been described. I will not go into the details. One paper test is there. Kensington test, which basically tries to hyperextend the same side joint. Or a pump-handed test, when you push the iliac limb towards the opposite shoulder. Or a Gillis test, again hyperextending the hip joint, which puts strain on the sacral joint. These are the 4 tests which must be done to authenticate whether the sacral joint is normal or not. Now this is spine examination. Any patient with spine disease is not complete with the time you have done a complete neurological examination. Again, the neurological examination has 6 sequences here. Higher mental functions are likely to be normal in your patient. In an orthopedic patient, they are likely to be normal, but just make a note of that. The higher mental functions are normal, and the patient is well already in time space and patient. Just make a very fast and comment about the clinical results, which are likely to be unknown in your case. Now the orthopedic neurological examination will go on examine the motor system, sensory system and reflection. Motor system each go in this sequence. Bulk, tone, power and reflection, you see them one by one. Bulk of the muscles is seen as well as measured. Make a visual impression whether the patient got resting or not. And once you are measuring it at the level of the thigh or the leg or the upper extremity, wherever the muscle mass maximum. You compare those areas on the 2 sides where the muscle mass is supposed to maximum. Now see this video carefully once again, then I will explain to you. Please see carefully. Now, increased tone in a patient of any disease could be either because of a class type or a corbel type. Corbel type is mostly because the extracellular lesion is not seen in our patient. It is mostly a class type of disease which is seen in our patients. What happens is when we try to flex the patient forcefully, this is once again. As you try to flex the knee, it gives an impression that there is resistance being given by the patient's body to resist that movement. But if you keep persisting, at certain point, it suddenly gives, at one point, then it suddenly gives way. Like in this patient. Now see carefully with that. This is a class type of. Once you have made a mark on the blood and the tone, then look for muscle strength to be, you know about this MRC scale, and you don't go into details of that. The muscle power has to be varied usually from 0 to 5. In a case of spine disease, once you are examining, you can go by groups, like knee flexors, knee extensors. But if the patient happens to be a case of polio, then you are supposed to go muscle by muscle. In a spine examination, you can go by group, whether the hip flexor is okay, hip extensor is okay, that way. If it happens to be a polio, then you have to tell muscle by muscle. Now, continue with the motor system examination. This is how you check the motor power. I have shown this video deliberately. First, I have seen many examinees. Once the examiner asks them to demonstrate the normal power, or the examiner says that the power is normal in quadriceps, and the patient examiner wants them to demonstrate. They will simply go put a resistance and the lower part of the leg and ask the patient to actually extend. Please do not do that. First do this maneuver and show that the patient has got at least grade power 3. Only when grade power 3 is there of quadriceps, then you can check for the further power. Once demonstrate this, then the grade 3 power is there, and now then you do the resistance, and then you tell the examiner the power is fine. Talking of reflexes, we have got two types of reflexes, deep reflexes and superficial reflexes. We'll see them one by one. Now, deep reflexes are stretch reflexes. Stretch reflexes means that you will put the concerned joint and a concerned muscle and then stretch and then stimulate it. This will elicit a reflex. The common reflexes which are to be seen in neurodevelopment in the outbreak cases is this in front of you. I need not tell you today, but you must remember the muscles involved, the cord segment, and the pericardium which is there. If you find a biceps, I'll give you an example. Please remember this chart. I'll give you a very common example. The commonest, just to collapse the thoracic spine is between C5 and C6. You find a biceps, reflex happens on the right side and on the left side, and patient has got a muscle spasm and history of neck pain. First diagnosis would be this collapse infection. Now, reflex is grade also. Many people don't know this. You can remember grading. Reflexes can be absent, this is grade 0, present like a normal ankle joint, present like a normal knee joint, very disc or clonus. I'll show you two examples. This is how you see the knee reflex. I told you the muscle is put on test, muscle and tendons are put on test. By this maneuver, when the patient is sitting, the person is put at test, or the examiner puts the person at test by slightly flexing the knee, and then tap the special tendon. This is an example of a normal knee joint. Example of hyperreflexia. Patient has got spastic palsy. This is how the ankle joint is seen. Ankle joint reflexes is seen. These are different ways. So one more way, one may make the like prone and flex the knee at 90 and then check the ankle flex. There are 4 ways of checking an ankle flex. This is an example of an increased ankle flex. This is how we check biceps reflex. Example is normal. Locate the biceps tendon with the thumb, and the nail of the lower thumb is hammered by you. Check it. Locate the biceps tendon. Flex the elbow ligament. Now the biceps reflex is checked. Example of normal biceps reflex. Now superior reflex is checked. Normal superior reflex. Brachial radius is contracted. You can remember that table. Hyperreflexia. The Hopper signing plan is a picture of neuropathy. This is a sudden flexing of the distal the terminal phalanx causes involuntary flexion of the rest of the fingers. Sudden flexing the distal phalanx or middle finger will cause involuntary flexion of the other fingers. See, this is a typical case of cerebral palsy. This is how we see the patellar conus. When the flexes are increased to the highest grade, then we get conus. This is how we see the conus, patellar conus. First see whether the patella is moving freely or not. It is not bound down by some additional free or free, and then check the patellar conus. This is an example of a patellar conus level. Now we check the ankle conus. These are typical ways we are supposed to do the exam. Now, superficial reflexes. This is a list of superficial flexes we are supposed to check. Superficial flexes are so named because we are stimulating a superficial part of the anatomy. We are stimulating the skin and we get reflex. That is why they are called superficial flexes. They have got a certain segment monitoring every superficial flex. If that particular flex is absent, means that there is a disease of that particular segment. This is important. Let's see how we restrict the abdominal flexes. There are two ways of restricting abdominal flexes. They are to be seen in all the four quadrants. In both the methods, we go from outer to inner side. This is one way of testing abdominal flexes. They are to be tested separately in the four quadrants. This is the other way. Again, we are going from outer to inner side. Abdominal flexes have got their own importance, but they have got their functions also. In many cases, they would be not properly assessed. Particularly in multi-para movement, a patient who has undergone abdominal surgery with a big scar, they may be absent. Their importance becomes really clinically relevant if it is present in the upper quadrant or absent in the lower quadrant or vice versa. If some quadrant is showing a flex and the other quadrant is not showing, it becomes much more significant. Otherwise, there are many instances, patients who are very obese, women who are multi-para, surgical scar, they may be absent. They will not have much of clinical symptoms at that time. But if you are able to elicit abdominal flex in a particular quadrant, but at the same time, the same patient in the other quadrant is absent, then it is not definite diagnosis. This is how we check for the plant response. This is a typical plant extensor response. Both are plastic parameter. The way of stroking the sore with the blunt object in a J-shaped manner, inverted J-shaped manner, starting from the outer part of the sole, take it up and then along the metatarsal arch. The typical way of doing it. You will see it once again. Preventive reflex, again, is not a very relevant reflex in adults, it will be normally absent. But again, it is absent, and it is typically seen in children. You see this, the testis moving up by stroking the skin of the upper thigh, upper middle thigh. The same side testis goes up. This is important. Many of you will not do it. Please, you must do it. Now, the examinee here has done wrongly with the needle. It should be done with the all pin. It should not be done with the needle. This is the injection needle. It should be done like this. But the method is correct. The instrument is not correct. The gloved finger open the anus, stroke the perineal skin with the pointed object, but not a hurting object, and you will see the anus pin. Bulbocaverous reflex. In a patient, in a female, it is the gloved finger inside the anus, please for the reflex. In a female, if she has got a disease and anybody catheters, one can pull on the catheter or press on the mouth pubis. I heard so many times that the females who stimulate the clitoris and chemotherapy, this is not done like this. In males, it can be by bringing the glass pin like the way it has been shown. Now, after motor system, you go to sensory system. You must remember this chart. This is important, both from your skill point of view. It is not uncommon to be asked from you to draw a diagram of the cross section of the spinal cord. But basically, remember these different tracks of the sensory track or pathway, and remember that. And as you know, the dorsal column tracks are mostly concerned with the proprioception, that is joint position and two-point discrimination, and a very small part of tract. The lateral tract and anterior tract are mostly concerned with the pain interpretation. One has to memorize these dermatomes. Now, in a particular case of disc collapse, in a particular dermatome will have a sensory loss. Then you can pinpoint the disc which is at fault. If the sensations are lost or reduced in a particular dermatome, one can safely infer the collapse. So please remember these dermatomes. These are all the modalities you can check, which are supposed to check and which is possible to check. The general principles, these are whether you go from normal side to abnormal side. As far as Hutchinson is concerned, Hutchinson says that we should go from abnormal to normal side. But most of the examiners, and we also in the examiners, would accept the method when you go from a normal area to a normal area. But I must tell you that the clinical method the Hutchinson says that we should go from an area of reduced or absent sensation to an area of normal sensation. These are general principles. How do you use a quantum risk? Please make a quantum risk like this to elicit the light action. Using a finger tip is also an internationally accepted method. You can use that method also, you will accept it. Then supervision pain is given with the ordinary pain, not with the hypodermic needle. You always use the pain. Or we have special pins made for this purpose available, particularly with the neurologist. Two-point discrimination, they are just complete the list. Two-point discrimination, you know that there are areas of the body which are supposed to discriminate two very near place points. The most sensitive area which can discriminate between two closely placed points is the tongue. Then comes the face. In orthopedics, the back is the last. The small distance between points cannot be recognized actually by the back. This is a described chart for telling you the different the distance between the 2 points for every area. This is how you check for the patient's joint strength. This is the main test which we are doing for the posterior columns. Please observe, I will spend a minute here. Patients should first see what is meant by the examiner up and down. We mostly done the lower limbs with the great toe. First explain to the patient what do you mean by toe going up and toe going down. Once you have explained the patient, then cover his eyes, so he is not able to see. Then hold the proximal phalanx of the great toe between the thumb and the index finger from the sides, not from the front, from the sides. And then give 4 or 5 movements to the IT joint and then take it to one side. And then ask the patient whether it is up and down. But before you do this thing, explain the patient with the eyes open, what is up and what is down. A tuning fork must be used. Again, the dorsal sensation will be lost in the case of, let us say, complete loss of spinal cord. The areas which are to be checked with the tuning fork orthopedically, the lateral of clavicle, the iliac, iliac spine, maybe due to velocity, valvular. These are the areas which to be checked for the resistance. This is pressure pain. I mean, even if you this will not be able to do in the exam. You must convince the examiner that I didn't have warm and cold water to test the test the food and cold. Now in the last one, this is the usual sequence you must describe in the usual sequence is found in your patients, and you must describe the exam also. The patient may be having a completely normal sensation in the upper part of the chest. As the fingertips start moving down, the patient may complain of reduced sensation, and that at a particular area, the sensation will totally disappear. It rarely happens that patient has got absolutely normal sensation above and there is a very sharp border and the sensation will disappear completely. So always make a note, mostly, I will not say always, mostly it will be like this, the patient has got normal sensation above D6. From D6 to D8, the sensation is 50% reduced. Below D8, that will be lost. And few patients have got a band of hyperesthesia also. It is in the spine. Patients have got a hyperesthetic band also sometimes. Make note of that also. The hyperesthetic band is very typical and is very diagnostic of a particular level. If that hyperesthetic band is there, one can pinpoint the disease location. must take note of bladder and bowel involvement, but I'm not going to details of this. Ear examination to complete the list. You may find a food abscess inside. Make a note of the bed source. This is the last slide. Most of you know it, but I'll repeat it. As you know, the spinal cord is shorter in comparison to the vertebral column. Vertebral column is long, spinal cord is short. But all the segments of the spinal cord are contained in that short spinal cord. Obviously, they cannot correspond to the level of the vertebral column. I hope you understand that. And the formula to remember this is, in cervical spine, if you are suspecting a disease of cervical spine T5, then expect the deficit to start at T6. From thoracic 1 to 6, add 2. If you feel there is a disease at T5, then dermatomal level will be T7. Remember this chart, this will be very clear. I will not discuss this case. I just try to tell you the usual scenario and what we are supposed to say in the diagnosis. I mean, most of you, once you have finished your case and the examiner asks you what is the diagnosis, you will say to go to therapy or for therapy. You may tell the date also for therapy and take course. Please do not go with this thing. Talk about extradural compressive myelopathy. Stage 4 biology as the patient has got complete paralysis. Vertical level, in this particular patient, the vertical level was not corresponding to this animal. Vertical level this much, dermatomal level this much. Extradural compressive myelopathy. Stage 4 paralysis, one of stage there. Vertical level this much and dermatomal level this much. Likely etiology tuberculosis. Your diagnosis should not be straight away tuberculosis or post-paralysis. In the case of extradural compressive myelopathy, these levels, I can discuss the etiology. It is likely to be tuberculosis. Example, bone transfer, other possibilities, tumor is other possibilities. To discuss that way, do not jump to tuberculosis straight away. Thank you so much. I have to take any questions. Next one.